Welcome to OncoTrial Insights with Dr. Pidugu, the podcast where we unpack the latest breakthroughs in cancer research and what they mean for patients and providers. I'm your host, Megan, and today's episode is all about a promising new treatment for advanced ER-positive, HER2 negative breast cancer. We're discussing the latest results from the EMBER-3 Phase 3 trial, a major study evaluating Imlunestrant, a next-generation oral SERD, in advanced estrogen receptor-positive, human epidermal growth factor receptor 2 negative breast cancer. Welcome, Dr. Pidugu.
Thank you for having me, Megan, and thank you to all listeners for tuning in. Before we begin, a quick disclaimer. The views expressed on this channel are solely my own and do not represent those of any institution, organization, or employer. This content is for educational and informational purposes only. Please consult your healthcare provider before making any healthcare decision. The information I will discuss is not meant to endorse or criticize any specific products or brands. My goal is to provide you with educational content, shedding light on various topics. All right, let's get into it.
Dr. Pidugu, before we get into the EMBER-3 Phase 3 trial, can you give a brief introduction to our listeners about breast cancer?
A breast cancer is the most commonly diagnosed cancer in women worldwide and remains the leading cause of cancer-related deaths among women. In 2024, more than 150,000 women in the United States are living with metastatic breast cancer. Breast cancer is classified based on hormone receptor status, estrogen receptor ER, progesterone receptor PGR, and presence or absence of human epidermal growth factor receptor 2 HER2 expression. Survival varies by subtype. At 48 months, the best outcomes are seen in HR positive and HER2 positive patients with a 45.5% survival rate. HR positive and HER2 negative comes next at 35.9%, followed by HR negative and HER2 positive at 33.9%, and then triple negative breast cancer at just 11.2%. In addition, metastatic breast cancer may be categorized via molecular subtypes. The 4 molecular subtypes include luminal A, luminal B, HER2 enriched, and triple negative, basal-like. Multiple mechanisms lead to resistance to endocrine therapy with or without cyclin-dependent kinase 4 and 6 inhibitors. Up to 50% of patients with endocrine resistance harbor the ESR1 mutation. Approximately 20 to 40% of patients who have received an aromatase inhibitor for advanced breast cancer develop ESR1 mutations. ESR1 mutations induce ligand-independent activation, causing resistance to endocrine therapy. Constitutive activity is a method by which ESR1 mutations produce resistance. The ESR1 mutated estrogen receptor auto-activates even in the absence of estrogen, leading to constitutive ER signaling. Endocrine therapy plus cyclin-dependent kinase 4/6 inhibitor is the first-line standard of care in hormone receptor positive human epidermal growth factor receptor 2 negative metastatic breast cancer. However, despite efficacy in treatment, disease progression inevitably occurs. There are multiple mechanisms of resistance to endocrine therapy with or without cyclin-dependent kinase 4/6 inhibitor. This trial, just published in the New England Journal of Medicine in March 2025, evaluated Imlunestrant both as monotherapy and in combination with Abemaciclib, a CDK4/6 inhibitor, in patients whose disease had progressed after aromatase inhibitors.
Dr. Pidugu, before we talk about Imlunestrant, can you explain why there's a need for new therapies in this space?
Definitely. ER-positive HER2 negative breast cancer is the most common subtype. While aromatase inhibitors are standard first-line treatments, many patients eventually develop endocrine resistance. One key driver, ESR1 mutations, cause the estrogen receptor to activate even without estrogen. That means current therapies can stop working.
That brings us to SERDs. What exactly is a SERD?
SERD stands for Selective Estrogen Receptor Degrader. Unlike drugs that simply block the estrogen receptor, SERDs degrade it like dismantling the antenna, not just turning off the signal. Fulvestrant, the traditional SERD, is given by injection and doesn't work as well in patients with the ESR1 mutations. Imlunestrant is different. It's oral, brain penetrant, and specifically designed to degrade estrogen receptor alpha, even in ESR1 mutant cancers. Pairing it with abemaciclib, a CDK4/6 inhibitor, might enhance outcomes even more. That's the idea behind the EMBER-3 trial.
Let's walk through the design of EMBER-3 trial. How was it set up?
Sure thing. This was a phase 3 open-label randomized trial for patients with estrogen receptor positive and HER2 negative advanced breast cancer whose disease progressed after aromatase inhibitors. Patients were randomized into 3 groups: imlunestrant alone, 400 milligrams once daily, standard endocrine therapy, oral exemestane or intramuscular fulvestrant, imlunestrant plus abemaciclib 150 milligrams twice daily. The primary endpoint was progression-free survival, first in patients with ESR1 mutations, then the overall population, and finally the combo versus monotherapy.
So how did imlunestrant monotherapy perform compared to standard endocrine therapy?
In ESR1 mutated tumors, imlunestrant significantly improved progression-free survival, 5.5 months versus 3.8 months with standard therapy. Over a 19.4-month period, the restricted mean survival time was 7.9 months versus 5.4 months, a statistically significant gain. But in the overall population, the benefit was minimal, 5.6 versus 5.5 months, suggesting that the advantage is mostly in the ESR1 mutated subgroup.
Now what about the combination arm, imlunestrant plus abemaciclib?
That's where things got exciting. The combo arm showed a median progression-free survival of 9.4 months versus 5.5 months with imlunestrant alone. That's a hazard ratio of 0.57, a substantial and statistically significant benefit. Importantly, this benefit held regardless of ESR1 mutation status and even in patients previously treated with the CDK4/6 inhibitors.
That's a big deal. Now let's talk side effects. What were the most common ones with imlunestrant?
With monotherapy, the most common side effects were fatigue, diarrhea, and nausea, mostly mild. About 17% experienced grade 3 or higher adverse events, which is similar to standard therapy. With the combo, side effects were more common. Diarrhea, 86%, nausea, neutropenia, and anemia. Around 49% had grade 3 or higher events. These are consistent with abemaciclib and were generally manageable with dose adjustments.
That's helpful context. One thing that stood out, did imlunestrant show any brain activity?
Yes, in an exploratory analysis, central nervous system progression at 12 months was just 1.5% with imlunestrant in ESR1 mutant patients, compared to 6.7% in the standard therapy group. This is likely due to its brain penetrant design, but more data is needed to confirm this potential benefit.
Let's compare imlunestrant to fulvestrant, our current go-to SERD.
Fulvestrant is injectable and less effective in ESR1 mutated cancers. Imlunestrant is oral, better tolerated, and demonstrated real efficacy in those mutation-driven cases. We saw similar trends with elacestrant in the EMERALD trial, another oral SERD. In both trials, the biggest benefits were in patients with ESR1 mutations.
So, the science is evolving, but there's still more to come.
Exactly.
So, what are the clinical takeaways from EMBER-3 trial?
Imlunestrant could become a valuable oral option for patients with the ESR1 mutant advanced breast cancer post-aromatase inhibitor therapy. And the combination with the abemaciclib may emerge as a new standard across a broader patient population. This could also encourage routine ESR1 testing and possibly push oral SERDs earlier in the treatment timeline, maybe even in the adjuvant setting, as trials like EMBER-4 are now exploring.
If we had to sum this up in one sentence, what would you say?
I would say imlunestrant represents a promising new tool, especially in ESR1 mutated advanced breast cancer. and its combination with abemaciclib could reshape treatment strategies across a wider population.
A game changer in the making. Dr. Pidugu, thank you so much for joining us and helping decode the EMBER-3 trial for our listeners.
Always a pleasure, Megan. Keeping up with the breakthroughs like this is what makes oncology so exciting.
That's all for today's episode of OncoTrial Insights with Dr. Pidugu. Don't forget to subscribe, leave a comment, and share this episode with your colleagues. Until next time, stay informed and keep advocating for better cancer care. Be sure to tune in next time for more updates on cutting-edge clinical trials.